I'm delighted to welcome all of you to the third day in the 4-day workshop on systematic review and meta-analysis, which is organized by Curio and CliMed Academy. Yesterday, we explored literature search strategies, study selection, and data extraction. Today, we will take another important step, which is diving into quality assessment and meta-analysis fundamentals. These topics will strengthen our understanding of how to critically evaluate studies and conduct rigorous statistical synthesis. Our first session for today is on the tools for quality assessment, which will help us in understanding how to ensure the credibility as well as the reliability of the studies which would be included in our review. We are honored to have with us Dr. Edlin Glane Mathias. Dr. Edlin is an assistant professor in the Department of Health Technology and Informatics at the Prasanna School of Public Health, MAHE, Manipal. A specialist in evidence synthesis, she has extensive expertise in systematic reviews, meta-analyses, and mixed method studies, addressing clinical as well as public health priorities. Her research spans pediatric pain management, digital health, health care equity, and health systems strengthening with publications in leading Scopus and Web of Science journals. She's also a TMFI Gold Medal awardee and has served as the editorial board of BMC Public Health and mentors early career researchers in evidence-informed practice. As a faculty at the Cochrane Affiliate Center at MAHE and an evidence ambassador for World Evidence-Based Healthcare Day, she actively promotes evidence-based decision-making and interdisciplinary collaboration. Dr. Edlin, it's my pleasure to welcome you on board for today's session. The virtual stage is all yours.
Thank you, Tanvi. Am I audible?
Yes, you are, ma'am.
Yes, okay. Thank you for that introduction. I will share my slide. Please
Yes.
confirm whether it is visible.
Yes. Yes, it's visible, ma'am.
Okay. I'll share it in the, yeah.
Yeah. Okay. Yes, ma'am. Thank you.
Yes. Okay. So, good evening, all. Hello, good evening.
Everyone's mic is turned off, ma'am.
Oh, okay. No problem.
Yes.
Okay. So, yeah. So, since 2 days, you had learned the different steps of systematic reviews, right from framing a review question, how to conduct a literature search, then how to go for the screening of the studies. Then today's class, we will learn on what are the different kinds of tools that you use for the quality assessment. So this stage, when we focus is like once you finish your full text screening, you'll be including studies, right? For your review. So those studies will be taken for the quality assessment. So in my today's presentation, I'll be talking on what is the importance of quality assessment, what are different kinds of quality assessment tools that will be used, then risk of bias assessment and reporting of the quality assessment. So since past 2 days, my colleagues had discussed like what are different kinds of hierarchy of evidence and where the systematic review and meta-analysis lies in the pyramid. So when we look at the bottom of the pyramid, the lowest quality study designs are considered to be high risk of bias. That means the cross-sectional studies, case control, or any other kinds of studies like editorials or expert opinion, they are considered to be high risk of bias and also considered as a low quality of studies. When we look at the top of the pyramid, we can see that we have randomized control trials, we have systematic review and meta-analysis. It is considered as the highest quality of the study designs and is also considered to have the lowest risk of bias. So since systematic reviews are top tier evidence, so thorough quality and risk of bias assessment are essential to ensure reliability and minimize flaws. So when anyone, any physician or any policymaker wants to take the evidence which can be used for their patient, or if they want to make any changes in their policy, so they will go through the systematic reviews instead of referring like a single RCT or a single any study design. So a systematic review has to be in such a way that the quality of studies what you include has to be good. So risk of bias assessment during systematic literature review. So why we have to do this and how we are going to assess the quality of the studies. So before that, we'll just go through what is the importance of quality assessment, like why we have to do the quality assessment. So quality assessment can be interchangeably used, like it can also be called as quality appraisal, critical appraisal, and risk of bias assessment. So when you look at the papers, those are already published, like systematic reviews. When you can see some papers, they might mention it as like quality appraisal. In some paper, you can see like critical appraisal, or as they can also report as risk of bias assessment. So it is one another the same. Systematic reviews produce robust, reliable, and reproducible results. They are still open to bias and errors. So, whatever systematic reviews it is existing in the literature, you cannot say that it is all of good quality, because even systematic reviews will have bias, and there might be any errors in the reporting also. So quality assessment minimizes the risk of bias and increases confidence in review findings. So to make it sure the studies what you are included are of good quality, so you will do the quality assessment and you will judge like each study how it is, whether it is of good quality or low quality. So now, what are the main things does the quality appraisal tool include? So mainly it will include, does this study address appropriate focused question? Did the study use valid methods to address this question? Are the valid results of this study important? Then are these important results applicable to my patient or population? So these are the like basic questions what you can see in any kind of quality assessment tools. So now we will see how different it is risk of bias and the quality assessment. So when we look at the focus, risk of bias assessment will mainly focus on the internal validity of the individual study. That means a study what you are going to take, mainly a randomized control trial and non-randomized control trial, we will focus for the risk of bias assessment. Whereas for other kinds of study designs like cross-sectional studies or cohort studies, case control studies, those studies we will mainly assess the quality assessment. So why we do this risk of bias assessment is we will in depth check whether the study has conducted in an appropriate way. So, but quality assessment, it will just overall look at the methodology of the study, how it was conducted and how it was reported. The purpose of risk of bias assessment is mainly, as I told, like it will try to identify all the potential bias in the study that has been conducted. But when we look at the quality assessment, mainly it will see how the study has been conducted, whether it is appropriate or whether it is complete in reporting. So common tools that are used is in risk of bias assessment. As I told, we will mainly focus for the randomized and non-randomized control trial. If you are using a randomized control trial, there is tool called risk of bias assessment 2, that is ROB 2.0, and Robbins 1. Mainly it is Robbins I, sorry. It is mainly used for non-randomized control trials. But for the quality assessment, you have different types of checklists like JBI checklist, CASP, AMSTER 2, and Newcastle Ottawa scale. And the judgment types in risk of bias assessment is mainly of three types, like low risk of bias, some concerns, and high risk of bias. When you look at the quality assessment, it has different areas like high risk, moderate risk, and low risk. And also there is option for critically low or good kind of study. Then application, mainly it is used in the systematic reviews, but quality assessment, it is mandatory in systematic review, but it is optional for the scoping review. So use in synthesis directly informs meta-analysis and grade. So if you are taking any studies for the meta-analysis, it is better you check the quality assessment as well as the risk of bias assessment. Based on that, they will focus on the grade assessment. So, quality assessment supports interpretation and presentation of the findings. So now we will see which are different kinds of quality appraisal tools that are used. Mainly, as I told, there is a tool called JBI Critical Appraisal Checklist. It is Joanna Briggs Institute Critical Appraisal Checklist, where it is commonly used, and you can through this checklist you can try to assess the quality of the studies across different study designs like randomized control trials, cross-sectional studies, case control studies, case reports, case series, cohort studies, quasi-experimental, diagnostic accuracy, economic evaluation, prevalence studies, qualitative research, systematic reviews. And if you are trying to include any expert opinion or narrative kind of policies in your review. So there is one more tool called as CASP tool. It is Critical Appraisal Skill Program. So this tool is mainly used to assess the quality of the cohort studies, case control studies, economic evaluation, and the diagnostic studies. Robbins I tool mainly, as I discussed, it is for non-randomized study of interventions. Robbins 2 for randomized control trials, and Newcastle Ottawa scale for observational studies, and SIGN checklist for cohort, case control, diagnostic, and economic studies. So now why we have to use this checklist? So without checklist also we can tell, right? Like whether the study is of good quality or low quality. But nowadays we have to follow the checklist which is already standardized, and those checklists has to be used which is suitable for the appropriate study design. So mainly why we use checklist is standardization, because if there is a standard checklist and standard items, based on those items the reviewers can assess what has been done and is missing from the studies. Then objectivity, reduce subjectivity by guiding reviewers through predefined criteria. So as I mentioned, the checklist will have the predefined criteria, and based on those items you're going to check the quality of the study. Comprehensiveness, it will help ensure that all relevant aspects of a study are covered. Like mainly you will check for the study design, the methods and reporting of the study. Transparency, make it clear how judgments were made, increasing the credibility of the review. Like suppose how you do the screening, like in the screening also you include two reviewers, right? And independently they will screen the studies. Similarly, for the quality assessment, two reviewers has to be independently assess the quality of the studies, and based on their judgment you will say the quality of the study is high or low. But sometimes what happens, like one reviewer will say the study quality is good and the other reviewer will say the study quality is moderate or low. So that time comes there is a bias in the judgment. So to have a clear decision, this checklist are mainly helpful so that you can go back and see what areas there was the dissimilarity between the reviewers. Then reproducibility, that is other researchers can replicate your assessment process and verify findings. Like suppose if you mention in your review that these many studies were of low quality, and once you finish your review you will publish. So the any other person or author is reading this your review, and that reviewer wants to go back and see based on the checklist. Okay, so you had mentioned your study, this study is of low quality. So the other reviewer has a so that they can go back and read that study, and they also can judge whether it is really of good quality or low quality. So it also serves as an excellent guide for novice reviewers learning to appraise studies. So we will see what are the standard appraisal questions that will be used across all the checklist. That is, did the study address a clearly focused issue? Is the sample size justified? Is the design appropriate to the stated topic? Are the measurements likely to be valid and reliable? Are the statistical methods described? Did adverse events occur during the study? Were the basic data adequately described? Do the numbers add up? That means they might mention 120 samples they had taken in the initial stage, but when analysis they might miss some of the studies or some of the samples, and they will just mention these many samples were included in the studies. Then was the statistical significance assessed? What do the findings mean? Are important effects overlooked, or what are the implications does the study have for your practice? So now we will see one by one the different checklist. So first is JBI checklist, a structured critical appraisal tool developed by Joanna Briggs Institute. So by their institute name only, they have mentioned it as JBI checklist. It offers different versions tailored to specific study designs. So as I told, they have different checklists for different study designs. It might be for RCTs, cohort studies, qualitative research, also for case report studies. So commonly used in systematic reviews and optional in scoping reviews when assessing the study quality. So this is how the JBI checklist looks, and this is mainly for the randomized control trial. So in one side you have a number of items that you will be assessing in the included study, and the other side you are having options for yes, no, unclear, and not applicable. So when you look at the questions, you can see that there are 13 items in the checklist. So the items are like, was true randomization used for assignment of participants to treatment groups? So you will read the items first, and based on that you will go back through the study which you are going to assess the quality, and you will see whether this question has been reported in your study, the study which you are going to include in your review. Then was allocation to treatment group consent, where treatment groups similar at the baseline. That means whether interventional control group, whether they were similar at the baseline, where participants blind to treatment assignment. Because we know that blinding plays an important role in randomized control trial. So you have to see in the article whether they have reported regarding blinding, where those delivering treatment blind to treatment assignment, where outcome assessors were blinded to treatment assignment, where treatment groups treated identically other than the intervention of interest was follow-up complete, and if not, where differences between groups in loss to follow-up described and analyzed. So in follow-up also, suppose the study had mentioned they had 3 follow-ups, like 3 months, 6 months, and 12 months. So they have to mention like initially what was their sample, and during 3 months what was their sample they could follow up, and how many in the 6 months and 12 months. And if there are dropouts, they have to mention how the analysis was done. So where participants analyzed in the groups to which they were randomized, like as I told, whether they had lost to follow up, then intention to treat analysis was applied to come to a common conclusion. Then where outcomes measured in the same way for the treatment groups, where outcomes measured in reliable way, like suppose they will mention in their methods, right, how they are going to assess their outcome. Similarly, they have to follow when they write their results. Was appropriate statistical analysis used? Was the trial design appropriate, or whether there was any deviations from the design accounted for in conduct and the analysis? So if there was any deviation, they have to mention in their manuscript like what was the deviation and why it was done. So based on this item, you are going to rate the study, whether it is of good quality or low quality. So now how to rate based on this number of items. So the more number of score you get, you say that the study is of good quality. And if the score is less, you say that study is of good quality. So now this JBA checklist doesn't provide you the what to say structured scoring. So the reviewers has to decide in the initial stage before they start with assessing the quality. So they can have a cutoff, like for example, you want to fix like from 10 to 13. If the score is between 10 to 13, the study is of good quality. And if 9 to 6, you want to say if you get a score of between 9 to 6, the study will be moderate quality, and less than 5, you want to fix like it will be of low quality. So it purely depends on the reviewers, but this has to be mentioned in your systematic review when you are going to publish. So based on these scores, we had assessed these studies. So now interpretation. Sorry, here I forgot to tell one thing. So each S will score as 1. So if you say S, it will be 1. So if all items you are saying it as yes, it will be a score of 13. And no and unclear will be 0. Even not applicable is also 0. Okay, so only you have to focus on the yes and no. So judgment here mainly, as I told, high quality will be the majority of responses are yes, that will say that there are minimal concerns, and moderate quality no or unclear responses means it is like you can say the studies of moderate quality or there is critical issues in the studies. Low quality multiple items are no or unclear, particularly in exposure outcome, measurement or confounding. So based on this, you will decide whether the study is of good or moderate quality. So this is one more checklist for cross-sectional studies. It is given by same institute, that is JBI checklist. So here the items are only 8 because the items differs based on the study designs. So here also you have the items and the analysis, that is yes, no, unclear and not applicable. So items are where the criteria for inclusion in the sample clearly defined. So based on the study design, the item will also change compared to others. Then where the study subjects and the setting described in detail, was the exposure measured in a valid and reliable way, where objective standard criteria used for measurement of the condition, were confounding factors identified. If there was any confounding factors that was identified in the study, they have to report it. Then were strategies to deal with confounding factors, whether they had found the confounding factors and whether they have stated like how they have dealt with those confounding factors, that has to be reported. Were the outcomes measured in a valid and reliable way, then was appropriate statistical analysis used. Here also scoring is like yes, no, unclear. So yes is 1 and no is 0, unclear is 0 and not applicable is also 0. Here also you have to decide how much cutoff you are going to give for high, moderate and low quality. So to show an example, JBI cross-sectional studies. So if you are having 5 studies, and you are having number of items, like 8 items were there for the cross-sectional studies. So you can mention like question 1 had mentioned that item. So I will give it as yes, question 2 yes, question 3 yes, question 4 yes, like that. So you have to mention. So each yes is you have to take a score of how many yes and you will say out of 8 how much you got. So in like Kumar et al, you can see 6 are yes. So out of 8, the score is 6. So 6 by 8, we say that it is a moderate quality. So you have to do it for the other studies also. So next is CAS checklist, that is critical appraisal skill program. So this tool is mainly used for qualitative studies, cohort case control, randomized control trials, systematic reviews, economic evaluation, and diagnostic test studies. And these tools are freely available in if you just type in Google, you can access those studies. It is available in the Word format, also in the PDF format. You can use it in the both version. So each checklist typically includes 10 questions organized into 3 main sections. So here in the CAPS checklist, they have 3 main sections. That is, are the results of study valid? Then what are the results and will the results help locally? So based on these 3 categories, the tool is structured. So this is how the tool looks. As I told, you will be having mainly 3 sections. That is, are the results of study trial valid? What are the results and will the results help locally? So based on each section, you will be having questions. Like for example, did the study address a clearly focused research question? Here also you have to say yes, no, can't tell or comment. So you can give a comment. Like if you say, if you see that research question is well defined, you can mention in the comment like what was the research question and how it was defined. So was the assignment of the participants to interventions randomized? If yes means yes, no. If you are not sure, you can tick for can't tell and you can give your comments. Where all participants who entered the study accounted for at its conclusion. So you have to mention what was the participants, how they were recruited. So where participants, staff and study personnel blind to participant study group. So you have to see whether blinding was reported, like how they were assigned to the different groups. Then were they similar during the start of the trial? Then aside from experimental intervention, were the groups treated equally? How large was the treatment effect? How precise was the estimate of the treatment effect? Can the results be applied to the local population or in your context? Were all clinically important outcomes considered? Are the benefits worth including those studies? So these all items you have to analyze based on the by reading your randomized control trial. So now how we are going to analyze? So if most answers are yes, the study is likely to be a methodological sound. Similar way, like how you do it in your JBI. So if it is yes means you will go give a score of 1, no means 0. Can't tell is also 0. So if you have no or can't tell responses, this may signal risk of bias. That means risk of bias can be in any areas like selection was not proper or performance of the study was not uh, like it was not done properly and attrition was not reported properly in the studies. So example of a CASP2. So now we will take an example of Smith et al. Study. So based on this checklist, it has 11 items and there are options like yes, no, can't tell, and they have also given the comments. So for the first item, the study addressed a clearly focused research question. So in their study, they have mentioned like children with asthma, impact of mobile app versus usual care. That means their research question was clear. So they have given a tick for yes. Then was the assignment randomized? They have given yes because they have mentioned which method they have used for randomizing the population in their study where all participants accounted for. Like yes, they have mentioned like intention to treat analysis method was used when there was dropout of the samples from the study. Then was blinding done, so they have mentioned like only outcome assessor were blinded. So where groups similar at start, so they have mentioned baseline characteristics were similar. Where groups treated equally, yes, they have mentioned same follow-up schedule and education was provided for the participants. Then how large was the treatment effect? So here you can see that 20% improvement in symptom control was found in the study. So how precise was the effect? So here based on the percentage, that is 95% confidence interval, they have mentioned like how precise the effect was. Can the results be applied locally? So they have mentioned in their study. So these findings can be used in urban clinical setting. Then were all important outcomes considered. So they have mentioned they had mainly checked for the control of the asthma, then quality of life and adherence for the treatment. So are benefits worth harms or costs? So no harms were reported and app was mentioned as the low cost. So these many what to say detailed description of the study has to be reported in the study, because sometimes we feel like even the randomized control trial will be of good quality, but it totally depends on the reporting, how the author has reported their findings, because nowadays we see that most of them have a pressure of publication. So what they will do is in a single publication they will try to publish as much papers they want. So in that case what happens is like same data you cannot repeat in other papers also. So you will try to limit the data. So based on that, when others want to do systematic review on your topic, so that time they will assess the quality, because if the all items are not reported in your paper, the quality of the paper will go down. So we have to be sure that when we are using any particular design in the study, we have to follow the appropriate checklist. Like for randomized control trial, we have consult like that. For other study designs, also there are different kinds of checklist where you have to follow it while you're doing the study as well as while you're going to report the finding. So next we will see the Newcastle Ottawa scale. This is mainly, as I told, for non-randomized studies. Mainly it is used for cross-sectional studies. So commonly used for cohort and case control studies, and it is developed by the Newcastle Ottawa group in 1993. So this tool is a different scoring where you will be having the star system. You doesn't have a scoring, like you will based on like these many items you will say that it is of good quality or low quality. So here based on the star system you will decide whether the study is of good quality. So here it is mainly has three broad items, that is selection of the study groups, comparability of the groups, and assessment of either the exposure or outcome of interest for case control or cohort studies. So this is how the tool looks. So as I told, you will be having three domains: selection, comparability, and exposure domain. And you will be having items in one side, and you will be rating the item based on the stars. So first item is adequate case definition. So if it is clearly defined cases or appropriate case definition, you will give a star of 3. So if your unclear case definition or poorly defined cases, the star will decrease based on the reporting you could find in the study. Representativeness of the cases. So if cases are representative of the population, so whether they have mentioned how they have selected their cases and how many are their cases in detail, if they have explained, then you will give a star of 3. If cases are not fully representative or cases selected without criteria, so in those cases you will decrease the stars. So selection of controls. So controls selected from the same population as cases or controls from a different population. So no proper selection. So we know that if case is 60 and control, we should always try to take either double or triple. So these policies has to be followed while recruiting the samples in case control studies. Then definition of controls, like whether they have defined who were their controls, how did they select, and what was their outcome of interest. Then controls with some characteristics of cases means you will give a star of 2. Poorly defined controls, then you will give a star of 1. Then comparability domain, mainly you will try to compare the cases and controls. If you find that cases and controls are comparable based on the design or the analysis, you will give a star of 2. And cases and control, you feel like it is not comparable, then you will give a star of 1. Control of important factors, that is adequate control for confounders and inadequate control for confounders. That means confounding factors they have to mention and how it was tried to eliminate from those studies has to be reported. Then assessment of exposure. So exposure is clearly defined and measured with reliable methods. So if they have used appropriate statistical analysis to do their defined to come to a conclusion, then you have to give a star of 3. Then somewhat they have defined means star of 2, and unreliable exposure, the measurement how or the analysis how they have done, then you will give a star of 1. Then same method of assessment for cases and controls. If it is same exposure assessment for both cases and controls, then you will give a star of 3. Different methods, if they have used, then you will give a star of 2. Unreliable exposure of measurement, then you will give a star of 1. Then same method of assessment for cases and controls. Here also same way, like same exposure assessment was used in between both cases and controls, or whether they had used different methods. Based on that, you will decide the star. So if there was no response rate, then here also you will mention like what was the response rate for both cases and controls, whether high non-response rate was found or very high non-response rate was addressed. So selection domains mainly depends on the maximum of stars. So in selection domain, you can mainly give a maximum of 4 stars. Then comparability domain, you can give a maximum of 2 stars. Exposure domain, you can give a maximum of 3 stars, and total score, it is maximum of 9 stars. So higher score indicates better study quality. 7 or more stars, you can say that it is of good quality. 5 to 6, you can say it as moderate quality, and less than 5 stars, you can say that it is of low quality. So this is how the example of Newcastle Ottawa scale looks like. So you will have the items of the tool and the study. So you can say that based on the previous slide, like if they have mentioned adequate case design definition, then you will give a 3 star, and based on their other categories, you will decide how the stars has to be given. So as I told, the maximum stars will be 9. So you have to score in each domain how many stars they have got, and you have to decide what was the final score of the study. So AMSTAR 2 checklist, it is mainly used to assess the quality of the systematic reviews. Even the systematic review can be assessed for their quality, whether they have followed all the steps adequately or not. So here this tool I'm not going to explain detail because this is the evaluation of the systematic review. So this tool, how they are going to rate is high, moderate, low, and critically low. So now once you finish your quality assessment, like how we are going to report it in your paper. Okay, so how many reviewers were involved? So as from starting, you know that since from screening, we have to include 2 reviewers. Okay. Similarly, for this quality appraisal also, you can include the same reviewers who were there during the screening, because they know the study well, because they were since that screening, right? So they will be able to better differentiate the study. So you can take help of the same reviewers. And if there is any disagreements involved, if yes, how it was resolved. Suppose if there was any disagreement between 2 reviewers, like how it was resolved, whether they had went back and read the study again, or whether still there was disagreement, and whether they took a help of third person. So this has to be reported. Then what was the quality appraisal tool they have used? Okay, because if you're having multiple study designs in your systematic review, you might use multiple tools. So each tool you have to report for which study designs you have used, and what are the scoring you had decided for each quality appraisal tool, and what was the total score you could give for the each study. So the number of studies you included in low bias, high bias, and unclear bias. So these many things has to be reported when you are writing a quality appraisal description in your systematic review. So next we will see risk of bias assessment. So before going for risk of bias assessment, we'll just see what is bias. So a bias is a systematic or methodological error that causes misinterpretation of the study's outcome. So bias can be in any areas of the study, might be during recruitment, that is selection bias, or during performance bias. While conducting the study, there was a misinterpretation, or there was error in recruiting the participants. Then a bias can be introduced in a study at any stage of the process, from formulating the research question, establishing the eligibility criteria for inclusion exclusion of primary studies, reviewing collected resources, to choosing which findings to publish. Even if you have done the study in a very good manner, but still selective reporting has been done, even that will cause bias in reporting of the findings. So now we will see what are the different sources of bias that we will see in any of the studies. So there are different kinds of bias, like selection bias, performance bias, detection bias, attrition, and reporting bias. So when we talk about selection bias, mainly comes the random sequence generation and allocation concealment. So we know that in randomized control trial, the participants has to be randomly allocated to the intervention and the control group. So this method has to be followed based on the standard methods that are suggested to go for the random sequence generation, whether it has to be by snooze method or computer generated method. Then how the participants were allocated, whether as I told, like snooze method was used to allocate the participants to the intervention or control group. So these all areas mainly focuses on the selection bias. So occurs at the start of a trial before allocation of the participants. So it will try to avoid the selection bias of the participants, determines a random order of assigning people into intervention and control groups, avoids systematic differences between groups, and accounts for known and unknown confounders. So if this step has been appropriately followed in randomized control trial, there may not be any bias in the selection process. So now when we will say it as a low risk of bias, so we know, as I told, like we have different methods for random sequence generation. Like we have computer random generator, we have random number table, or stratified or block randomization we use. And sometimes they also use like coin toss or shuffling card or envelopes, throwing dice, drawing lots. So when you see a randomized control trial, they have to mention in their study how randomization was done. So in some of the papers, what we see is they just write like randomization was done, or it is a randomized study, but the method of doing randomization is missing, or they may not have reported. So that will lead to the assessment of high risk of bias. So, or else they might have mentioned like a randomization was done based on like date of birth, day of visit of the patient, or if there what to say, odd or even number they had allocated, or just a record number of the hospital record number. So if those kind of things they have used, but still they have mentioned it as a randomized control trial. But we know that is not an appropriate method for the randomized sequence generation. So in those case, we will mention that study is a high risk of bias. Or they mention it as like non-random choice of clinician of participant, test results, or the availability of the participants. So next is allocation concealment. So this will occur at the start of the trial during allocation of the participants to the groups. So it will try to avoid selection bias. So when a person is recruited to the study, no one can predict which group they will be allocated to. So even the researcher and participant should not know which group they are going to be get allocated, whether intervention or control group. So we will try to conceal this process. So it will try to ensure the strict implementation of the random sequence generation. So by following this method, it will try to prevent changing the order and prevent selecting who to recruit. So this kind of bias we will try to avoid in allocation concealment. So now when we will say it as low risk, suppose now allocation concealment they have mentioned it was done by phone method, web method, or any pharmacy method they might have used, or that time we will say it as like allocation concealment because it was not done by the research, it was done by someone else. Or else you can also use the snooze method, that is sequentially numbered opaque sealed envelope and sequentially numbered identical drug containers. If those methods has been used, you can create these studies of so a low risk of bias. Then high risk of bias when you say is you mentioned that in the authors has mentioned that random sequence known to staff in advance or as the author itself, the researcher itself had known how like whom to recruit for the intervention and the control group, or the envelopes or packaging without all safeguards, or they used only a chip method to recruit the participants to the intervention and control group, or non-random methods. If those methods were used, we will see it as like a high risk of bias. So next is performance bias, that is blinding of participants and the personnel. So here mainly you will try to avoid the performance bias. So different treatment of the intervention groups and different participant expectation that will lead to changes in the actual outcomes. So it will try to assess carefully like is it likely that blinding was broken, or consider impact even if not feasible for this intervention. So when we say it as low risk is blinding and unlikely that the blinding could have been broken, no blinding or incomplete blinding, but outcome unlikely to be influenced. So when we mention it as like high risk of bias, like no blinding or incomplete or broken blinding, and outcome likely to be influenced, because the researcher has to mention in their article like who was blinded, whether the researcher was blinded in the recruitment process or during the outcome assessment, or whether the researcher was blinded, because in some cases there is not no possible to blind the researcher. Sometimes that study has to be kept open label. So in that case, it depends on the study, whether the blinding was really required or not required. So simply we cannot say like they had did not mention blinding, so we will grade it as a high risk of bias. So next is detection bias, blinding of outcome assessment. So it will try to avoid detection bias, measurement of outcomes affected by knowledge of the intervention received. It will try to assess carefully, and study can be single blinding and double blinding. So double blinding is even the researcher as well as the participant will not know regarding like where they are going to get recruited. So is it likely that blinding was broken? Like sometimes the blinding will be broken in the study. So if it is like they have to mention like why it was not possible to blind the researcher or the participant. So maybe feasible even where blinding of the participants and care providers is not. Remember that participants and personnel may also be outcome assessor. That's what I told. Because since we cannot say that researcher or else the participants were not blinded during the outcome assessment. It depends on the study where the blinding is really required. So low risk like blinding and unlikely that the blinding could have been broken, or no blinding but measurement unlikely to be influenced. So if you could see by reading the study, there was a need for the blinding, but still the study researchers, they did not blind the concerned persons, like it can be like researcher, participants, or outcome assessors. So in that case, you can go for like high risk of bias. So assessing blinding of the outcome, so it may reach different conclusions for different outcomes. So measurement of only some outcomes may be blinded. Only some areas they have blinded and some areas they have kept as open label. Or it can be like subjective outcomes may be more vulnerable to bias, or may apply to both performance bias and detection bias. And it is option to design your table with two or more outcome and groups for these categories. Next is incomplete outcome data. So this is like when you find like the outcome, the data what they have reported in the study, it can be in the form of outcome of the participants. It is not available for the review, or you can see that there is a attrition level or loss to follow up, or there is withdrawal from the study, or if there is any missing data from the study. So exclusion, some available data not included in the report, might be only positive data they have included in the study, or negative findings that did not report in the study. This can also lead to the attrition bias. So now considerations, how much data is missing from each group. So that has to be checked. Whether so much there was a missing of data, or they included only few numbers where there was like positive findings, and when there were numbers with negative findings, so that they did not report. Then why is it missing? Then how were the data analyzed? So as I told in my previous slides, like if there was loss to follow up during like 3 months, 6 months, 12 months, you have to report like how much was the follow up, how was the analysis was done. So low risk, when we consider it as like if there is no missing data, like all the outcome assessment was done based on the recruitment samples, then there is reasons for missing data not related to outcome, or missing data balanced across groups and reasons similar. That is when you try to use the intention to treat analysis, and you will try to balance the findings for your randomized control trial. Then proportion missing or possible effect size not enough to have a clinically relevant effect. So when you say it as a high risk, like mainly the reasons related to outcome and imbalance in numbers or reasons, you find that there is no appropriate data where they have mentioned like what was missed, like how many data samples they try to analyze, then proportion missing or possible effect size enough to have, then clinically relevant effect as treated analysis with substantial departure from allocation, inappropriate use of imputation. So you can take help of statistician if you're having some dropouts, so that they will try to adjust based on the intention to treat analysis. Next is selective reporting. So based on this selective reporting, mainly you will see that some of the papers, they only report what to say the positive findings, that is statistically significant findings only be reported, or else they will try to adjust their data so that you will get a significant p value, or outcomes measured or likely to be measured but not reported, outcomes as they added, statistics changed, subgroups was applied, then reporting that cannot be used in a review, refer to a study protocol or trial register. So some of them, some of the authors, what they do is they publish their protocol. So in the protocol, they had already mentioned like how they are going to recruit their samples, how many samples they will be including in their study, and how the analysis will be done. But when they publish their main paper after they complete their main study, but the selective reporting has been done, or it doesn't follow the protocol. So that time there will be a bias. So when we say it as low risk, like protocol is available and all pre-specified outcomes of interest to the review reported based on your protocol. Or protocol not available, but all pre-specified and expected outcomes of interest are reported. That means you had prepared protocol, but you may not have published your protocol, but you have stick to your protocol like based on what you have decided in the prior. When you say it as high risk, like outcomes not reported as pre-specified or expected, or there is any missing data, or you have added some data, or subsets or unexpected measurements were done, or outcomes reported incompletely, so they cannot be entered in a meta-analysis. So those kind of reportings, if you could find in the study, you will mention it as a high risk of biased. And most of the studies, if you find that the judgment is not proper, then you can give it as a unclear risk of bias. Then other sources of bias can be many things. Like for example, if there is a small sample size, if there is any diversity of the population, like inadequate dose or unusual population, or other measurements of quality, like ethical approval was needed for the study, but it was not taken, or funding they might have received in the study, but they have not provided the data who was the funders. So those kind of thing will be like other source of bias. Here also you have can mention as low risk if you find a study appears to be free of other sources of bias. This depends on the authors, those who are checking the quality of the study. By reading the study, you can understand whether it is of whether it has any other source of bias. Then high risk of bias, when you say like whether there is an issue with the specific study design or carryover in crossover trials, recruitment was not done properly, or non-randomized studies or baseline imbalance was there, or block randomization in unblinded trials, differential diagnostic activity, or there is any other source of bias. So we can use the Cochrane's risk of bias tool. So it has mainly 7 domains where you will try to assess the risk of bias assessment, and based on the color coding, that is yellow indicates that is low risk of bias, red is high risk of bias, and yellow is unclear risk of bias. So this is how the Cochrane risk of bias tool looks. So you are having different domains like risk of bias arising from randomized process, then other domains on selection, reporting, and other sources of bias. So you will be having signaling questions in the tool, and you have to provide your comments, and there is a response where you can see as Y as yes, P Y as partially yes, P N is partially no, N is no, and Ni is no information. So as in my previous slide I had discussed, it will try to see the study randomized control trial in detail. Like for example, allocation assessment, how the allocation was done, how the concealment was done, what was the group between when they were in the baseline, and you will give your risk of bias assessment. So if it is low risk of bias, you can give a tick for low risk of bias. And there is an optional area like what is the predicted direction of bias arising from randomization process. If you say that the study is good and it is you say that it favors experimental or favors comparator, you can decide based on the reading the study. So there are other questions like other domains like risk of bias due to deviation from the intended interventions. So here you have different signaling questions for the each domain. Like here you have where participants aware of their assigned intervention during the trial. So we know that patients should not be, or patients or participants should not be aware like which group they are going to assign. So here based on that judgment you have to give. If you say yes means we know it is high risk of bias because we know that participants should not know which group they are going to get assigned. Similarly, you read 2.1, 2.2, and if you say that 2.2 is yes, then you have to answer the 2.3 question. Similarly, you have to follow the previous question and you have to answer. So if you say no, then it will say you have to go to the next question and provide your judgment. So this tool will try to assess all that domains like which we discussed in the previous slide, like selective reporting, randomized allocation, and how the assignment was done for the groups. So this is bias due to deviations from the intended intervention. So here you have to see where participants aware of their assigned intervention during the trial. Then they mention like if applicable, then you go to the question 2.1 or 2.2, like where important non-protocol interventions balanced across intervention groups. Then if it is applicable, where there failures in implementing the intervention that could have affected the outcome. Then if it is 2.5 applicable, was there non-adherence to the assigned intervention. Then 2.6, if no or partial no or no information to 2.3, or yes or partially yes, no information to 2.4 or 2.5. So you have to be thorough in your previous question. So it based on that, your next question will decide. So next is missing outcome data. So here you have to see what was the data that is missing from the studies which you read. So where data for this outcome available for all or nearly all participants randomized. So they have to mention like how the randomization was done, or how many they could randomize or did not randomize. Then similarly, it will signal your next question. If no, partial no, no information, go to 3.1. Is there evidence that the result was not biased by missing outcome data? So this you have to analyze by reading the study which you are going to assess the quality. Similarly, 3.3, like if no, partially no to 3.2, could missingness in the outcome depend on its true value? So 3.4, if yes, partially yes, no information to 3.3, is it likely that missingness in the outcome dependent on its true value? So all this item, no, if you are not clear, like if you could not understand, you can refer the Cochrane handbook. So each item they have explained in their Cochrane handbook. If you open this chapter for risk of bias assessment, each item they have mentioned like what they meant by those questions. So before starting a risk of bias assessment, once you can read like what this item is and what it indicates, like what you have to find from your study. So next is risk of bias in measurement of the outcome. So here also you have to see how the measurement of the outcome was done, like was the appropriate method used, or whether there was any assessment between the outcome of the groups. If no means, if no, partial no, no information to 4.1 and 4.2, it will try to give you one more question. So similarly 4.4, if it is yes or partially yes to the previous question, then you have to address the 4.4. Similarly, 4.5, if yes, partially yes, no information to 4.4, is it likely that assessment of the outcome was influenced by knowledge of the intervention received? So this purely depends on your judgment by reading the study, whether you want to say it is of low, high concern, or some concerns that are available in the study. So next is risk of bias in selection of the reported results. So here, based on the results they have reported in the study, you are going to analyze whether there is a bias or not. So where the data that produced this result analyzed in accordance with the pre-specified analysis plan that was finalized before unblinded outcome data were available for the analysis. Like as I told, like you have the protocol for the study what you are going to do. So it was followed. Based on that, the outcome assessment was done and the reporting was provided in the study. So then based on assessing the domains of the each study, you have to discuss the overall risk of bias assessment of the study, whether this study is of low, high risk, or whether it is having some concerns in the study. So now completing the assessment, as I told, like we have to include at least two assessor, and each study has to be independently assessed for the quality by two reviewers. Ensure all understand the methodological issues. So as I told, just by reading once, you may not understand the tool. So before starting risk of bias assessment, you just read the tool and try to understand what are the components they are going to address. Then include content and methods experts. So you can include some of the methodological experts, those who know how to do this assessment, and always try to pilot test on 3 to 6 studies before exactly starting the quality assessment, so that you both reviewers are having same judgment. Look for missing information, because sometimes, as I told, like the study might have done in a good way, but the reporting was done based on, like as I told, only selective reporting is done. So that time also it depends on the quality of the study, and always try to check whether there is any study protocol on the same topic, I mean same study. Then always try to contact authors if you find like protocol is there and there is some missing data in their published study. So you can try to contact authors and see to provide the missing data. Then risk of bias table we have to prepare once you finish your judgment. So this is how risk of bias table which you can make in review manager software. So this kind of table you could find where you can write the name of the study which you are going to assess, and there are different category in the author's judgment, that is high, low, and unclear risk of bias, and you can always try to support for the judgment based on your finding. So now how we are going to presenting the risk of bias? Mainly two diagrams are important, that is risk of bias graph and risk of bias summary. Where risk of bias graph, where you can see based on the each study, like domain one, like selective bias, reporting bias, attrition bias. So those are the 5 domains which you had checked in your Cochrane risk of bias tool, and the overall risk of bias judgment based on what you are going to convey. So now what to include in a protocol? So always try to brief description of risk of bias assessment tool, then list the domains which you are going to assess, refer the Cochrane handbook, that is chapter 8, and more than one author will always try to assess the risk of bias. Then how will disagreements will be resolved? So you have to be very sure if you are having disagreements, how you are going to report it. Then are there specific domains you consider to be important for the review? Then how will you incorporate findings in your analysis? So this is one of the example, like how we are how this tool looks. It's only domains I have mentioned in this slide. So for example, as I told, based on the 5 domains, you have to mention if there are 3 studies, so you have to mention like what was the randomization in Smith study, like low. Then in Kumar study, they have mentioned as some concerns, and Lee study it has mentioned as low concern. So based on each domain, by going through the study, you have to mention what it say convey for the each domains. Yeah, so this is regarding quality assessment tools, and these are the references for the quality assessment and risk of bias assessment tools. So thank you for your patient listening. Yeah, if you are having any doubts, I think you can see.
Thank you, ma'am. Would you like me to read the questions for you?
If there are in the chat box, I will see.
Yeah, there are some in the chat box.
Okay, so are the tools for designing the study and assessing the quality same? Designing the study, you are having a checklist, like for each study you are having checklist. As I told, if you are going for the randomized control trial, you have a consort checklist. Similarly, you can go for the you can check in equator network, where you will get different kinds of checklist for the each study, where you can try to see the each components are addressed in those studies. But if you want to assess the quality of the study, you can use this checklist. But if you follow the checklist to conduct the study, so that if you can mention based on those findings itself. Okay, so we have to submit this process data as an additional supplementary materials for publication. Yeah, if you want, you can submit this checklist as the supplementary form, or else you can just report in your manuscript itself, like how many studies you had checked, what was the tools used. If needed, you can also submit as a supplementary file. Okay, is there a difference between cross-sectional study and analytical cross-sectional study? Yeah, can we add multiple study design in systematic review? Yeah, systematic review, you can include any kind of study design. Like there is no like you want to include only RCT study or cross-sectional study. Any kind of study designs you can include based on your research question. What is the study design in systematic review? There is no any study design in systematic review. Like what kind of study design you're going to include in your systematic review you have to mention. Do we need to do two things? One is appraisal and other is risk of bias of each study. Yes, as I told, if you are including randomized control and non-randomized control trial, like that time you have to assess the risk of bias assessment studies, like quasi experimental studies if you are including and randomized control trials, you have to go for the risk of bias assessment. But if you are trying to assess only quality of, like what to say, cross sectional studies, case control, those kind of studies, you can just go for the quality assessment. How do you write its discussion and conclude the study? That's what you can justify, like why you had did the quality assessment, like what was the tools that you have used and what findings you could find in your review. Yeah, so you have to check for all the included studies which you have included in systematic review. All studies has to be checked for the quality assessment. And in your review, it is no like you will include only high risk of bias studies. You can also include a low risk of bias studies, but you can have a separate analysis. Like might be Elston will discuss in his next class. So how we are going to do meta-analysis for the low risk of bias studies and high risk of bias studies, but you will not exclude it from your uh, review. How to check availability of protocols for selective bias? So that's what I said. Like if the authors have published their protocols and it is publicly available, then you might be able to check for the protocols. If they have not published their protocols, then you may not be able to check for their protocols that is available. Otherwise, you can try to contact the authors and say. So yeah, regarding this AI agent, disclose it before. Yeah, it's better this we will not use AI for risk of bias assessment because it is like personal judgment. As I told, even the tool doesn't give you the proper scoring. So by reading the article itself, you will judge whether the study is of good quality or low quality. So it's better a human being itself will check the quality of the study instead of depending on the AI, since it is a systematic review. Okay, so these are the questions what I could see in the chat. Is there any other questions who want to unmute and ask? Are the mics accessible?
No, ma'am. If anyone has any, then we can probably make them unmute themselves, sorry. Are there any questions? If you have any questions, we'll be waiting for 1 minute. Kindly put them in the chat box.